So today we are going to talk about ADHD in women, in particular during pregnancy, postpartum, and it was really interesting to prepare this talk because it's so different in females than in males in many things, and it's so unrecognized that I think it's really important to know about it. So let me share my screen. Okay, can you see my screen? Okay, perfect. So I wanted to give you some context and some data. So what is the prevalence of ADHD in general? So in children and adolescents, it's 3 to 7%, in adults 2 to 5, in women 3.2. The rate male to female in childhood is 3 to 1, and male to female rate in adults is closer to 1 to 1. Some of the thoughts about this is that it might be some genetic thing, that it's more common in males when they are little, and it appears later on in female. But there is a lot of thoughts about the fact that it's not recognized in girls, and it goes really underdiagnosed and undertreated. So it might be that way is a reason that it's not recognized. It's this male to female ratio is the fact that some girls are not recognized with ADHD, and we'll talk more about that why. So girls are underdiagnosed and undertreated with long-term consequences, and mostly are girls that they have the inattentive type or inattentive symptoms, because they are not so like males may have more of the impulsivity, the hyperactivity, and they are more noticeable to teachers and to family because they are disruptive. On contrary to that, inattentive girls are more to themselves, they don't bother, they are daydreaming, and they might just go unrecognized. And adult ADHD is also underdiagnosed and undertreated in general, and we'll talk more about that. So from the ones that have it during childhood, there are different numbers in studies, but some studies suggest that up to 80% will go on to have it in adulthood. And from those, in a longitudinal study, they saw that one third of all this population of women that had ADHD in childhood, a decade later, continue meeting full criteria for ADHD. And one third continue meeting partial criteria for ADHD. And 10% of the sample had impaired functioning, which is very important to know and to keep in mind. So ADHD is very common comorbid with other psychiatric conditions, and these conditions can mask the ADHD presentation and can make it hard to recognize the ADHD. So in adults, you can see people with autism, with anxiety disorders, depressive disorders, bipolar disorder, eating disorders, personality disorders, substance abuse disorders, impulse control disorders, and also learning disabilities. And all these, when they have symptoms of these other conditions, can make it very hard to diagnose the ADHD. And we'll talk now when we talk more about the presentation. So what it looks like in females ADHD. So they can present with both, with the inattentive type and the hyperactive impulsive symptoms. They might have lower severity symptoms, less of the hyperactive impulsive symptoms, and more of the inattentive. And what it looks like when they have the inattention symptoms is that like they are easily distracted, disorganized, overwhelmed. They seem to lack in effort or motivation, and symptoms are pervasive, and they really impair their functioning. They are not like transient and fluctuating. And symptoms are more obvious during times of transition, social transition, educational transition, or hormonal transitions too, during postpartum, during changes in, there are some studies that suggest that symptoms get worse with hormonal changes during the menstrual cycle, during pregnancy and menopause. And one study, they saw that women with ADHD were more vulnerable to have the hormonally mediated mood disorders like PMDD, postpartum depression, perimenopause depression. So this is very important to know because it's not the same that in men. So females usually suffer from more general impairment in intellectual functioning. They have more emotional lability and mood dysregulation. They have more problems in social life, in interpersonal relationships. They are more vulnerable to bullying, both including physical, social, and cyberbullying. Men are more vulnerable to physical bullying. Women are more vulnerable to social and cyberbullying. And these females tend to become sexually active earlier than their peers and may have more number of sexual partners. And they might have more rates of sexually transmitted disease and unplanned pregnancy. And that's very important for us because they might have also unwanted pregnancy. And they are more at increased risk of having been the victim of sexual and physical violence. So we knew from a long time that antisocial behavior was comorbid with ADHD. They thought it was just in males. They see now that it's also in females. The rates of ADHD in prisoners is similar in males and females. And these females have as I said before, they have more impairment in functioning. So they have more school dropouts and underachievement. They have increased rates of accidents and mortality. Substance abuse, it's also something that can happen, and they use it a lot to cope with the emotional turmoil they feel, the social isolation, and the feelings of rejections. Because when they are having problems in interpersonal relationships, they can be bullied and they can also feel rejected, and end up with social isolation. And they have increased addictive social media use and unsafe or reckless driving. This is very important because for me, it's one of the indications to treat a woman during pregnancy is when they are having problems driving, because that's very risky. In terms of substance abuse, so what I wanted to say is that women might use different coping skills to deal with their ADHD, and some can be healthy and some can be unhealthy. And so substance abuse is a way of coping that is unhealthy. So there are no real studies that showed us the course of ADHD in pregnancy and postpartum. There is this general belief that women can have the pregnancy brain, which means like more forgetful, more inattentive. But studies so far about that, and that's not just in ADHD, in any woman, it's supposed to happen. But in studies that we have, the results are inconsistent about this, about women having impaired neurocognitive functioning in pregnancy. And I read studies that said, yes, that can happen. And in the postpartum, it gets better. And I read studies that said, no, there's nothing like that thing of pregnancy brain. What we know is that pregnant women with ADHD are more likely to smoke up to the third trimester or to be obese or underweight. And there, as I said, we don't have much data about what happened in the course of ADHD in pregnancy and postpartum. But they did a study. It was a small study where they followed women with ADHD during pregnancy. And actually, 1/3 of women continue their medications and 2/3 stop them. And some of these women had comorbid depression. So some of these women were on antidepressants. So most of the women continued their antidepressants. What they saw is that the ADHD symptoms didn't change during pregnancy, but women who stopped their stimulant for pregnancy had an increased risk of depressive symptoms, and also significant impairment in family functioning, like parenting, enjoying their family. So, and they were taking their antidepressants. So that's really interesting to me, that it seems that the stimulants were helping them. And these women that stopped them had more symptoms, depressive symptoms. So the diagnosis of ADHD, there are rating scales. We have the clinical interview and we have collateral information that are important. Rating scales, because most of the literature is based in males, rating scales too, a lot of them are based in males. And we have to be very careful to interpret the cutoffs, because, as I said, most of them are based in males, so it might not be the same cutoff that you need for a female. But the other thing is that you need to really base your diagnosis in your interview, in what you see about a patient. Rating scales can help, but they are not the whole story. And not all scales, as I said, focus really are done for females. Some of them most of them are more for males. And so in case that you are using one that is not done for females, you might need to ask more collateral information. And here I put 2 of them. There are several rating scales. The corners has for children and for adults, and you have for the person and for the collaterals. But they have specifics for females. The adult self-report rating report scale, it's done for males, but we use it a lot for females too. But it's not particularly done for females. So the clinical interview is very important to check for comorbidities. As I said, it's very, very common, primary or secondary to ADHD. That's very important to know and to kind of figure out, because it will change your course of treatment. If you are thinking that the comorbidity is because of the ADHD, it might make more sense first to treat the ADHD. If you think that both are at the same time, you will decide which one to treat before. Check for compensatory mechanisms. As I said, some of them are functional and some are very dysfunctional. What I see a lot is that when women get to adulthood and they have ADHD for many years and it went undiagnosed, they already have a way of functioning and they have a way of dealing with things and dealing with their weaknesses. And that's very interesting to me. Like, I saw a patient the other day that she had very clear history of ADHD since childhood that was never diagnosed. And she had her way of dealing with it, in terms of how she was taking notes, how she was doing lists, to-do lists, how she was putting alarms. So she really had ways of dealing with it without knowing that she had ADHD. Then, very important to check for safety. There is a higher risk of self-injurious behavior in this population. And as I said before, there is an increased risk of behaviors that can be risk-taking, like having sexual intercourse with multiple people, driving fast or recklessly, getting into violent relationships, or having situations that put them at risk. Then it's very important to ask about sleep. A lot of these women have sleep problems too. And the other thing that they suggest that it's very good, very helpful, is to have collateral information from somebody from the family that can tell you how this person is functioning, what symptoms they have, what they think. What is very important for me is that you need to be mindful that because ADHD is so highly genetic in terms of how it's transmitted, some family members may also have ADHD. And when you ask a patient with ADHD, they will tell you, yes, my mom has it, my brother has it, my sister has it. So it's very common that it runs in family. And so for these family members, it might be very common, the symptoms, and they might not seem pathological. So they might minimize what is happening with your patient, you know? So you have to be very mindful when you interview a family member. So, but we know that prompt diagnosis and treatment really improves the outcome. And there is evidence of long-term functional benefit associated to treatment. So the best treatment is a multimodal one that will include medications, will include psychoeducation, and will include therapy. And in terms of therapeutic interventions, you can decide what is better for your patient, if a group or individual therapy settings. Cognitive behavioral therapy intervention seems to be very helpful, particularly when it is directed to improve the ADHD symptoms, the executive dysfunction, and the comorbid conditions, and what we were talking before, the dysfunctional coping mechanisms that the person is using. So it's always very important to focus on the positive things of the patient so they don't feel more, because many of these patients have very low self-esteem. So you want to identify and focus on their strengths and positive attributes, not to make them feel worse for their condition. Always discuss about their sexual health and safety, make sure they are not, it's important to identify and help them in therapy with not getting into situations that can be very risky for them. And the other thing that is very important is what happened with a mother, what happened with a woman that has a baby and she has ADHD. That time of the life, it's very, very difficult because it's not just that she was trying to function and the way she was trying, and maybe she stopped her medication, and then suddenly she has to take care of this baby, and that's a lot of pressure and changes routine schedules. So helping them with life skills, coaching, guidance, and supporting parenting is very important. And then also for women when they go back to work after having a baby, focusing on occupational issues. There is a lot of literature about these women having interpersonal difficulties at work. So it's very important to focus on all this. In terms of medications, there is a trend to use more stimulants during pregnancy. So as you see here, in one study, they show that the use of stimulant increased in pregnancy from 0.9 in 2003 to 4% in 2015. Some things to consider, very important. One is that these medications as a side effect can suppress appetite. And that's very important to have in mind when you're treating a woman that has comorbid eating disorders. Always consider the risk of substance abuse. That's something that is very concerning to me. When I give a stimulant, I want to make sure the patient doesn't have a history of substance abuse. Then what I was talking before is that if they have a comorbid, let's say depressive disorder, and the symptoms are not pervasive, are more like related to the moment, it seems, you might want to treat first the ADHD and monitor for improvement of symptoms before starting a medication for a mood disorder. And this I did in the past. When I see the ADHD and a woman comes also depressed because of her ADHD, I treat the ADHD, and that gets the depression much better or the anxiety much better. And it's so good to see, so rewarding. There is some data that ADHD medications can affect women differently during their different times of their menstrual cycle, like premenses. There are some data that suggest that stimulants can make the euphoric effect of the stimulant can be enhanced during the premenses time. So that's important to have in mind. Women can become more irritable with it. It's not that every woman will happen this, but it can happen in some women. And because women are so susceptible to transition, it's very important to monitor them closely and reevaluate the treatment every time there is a transition and a time of hormonal changes. So in terms of medications during pregnancy, so most of the information we have was from when people used to abuse these medications, and also women that abuse cocaine, So later on the last few years, several years, women started taking stimulants more for ADHD at therapeutic doses. These were women that weren't abusing them. And that brought up more literature about stimulants during pregnancy. So there are two main categories of stimulants. One is the methylphenidate and then the amphetamine salts. And studies, most of them suggest there's no risk of cardiovascular or congenital malformations with these medications. There are just two recent large studies that suggest a small significant association between the use of methylphenidate in pregnancy and cardiovascular malformations. But the absolute risk is really a little bit elevated. So this is very important. I always explain this to patients, that what is important is what is the absolute risk. Because you can say it's increased 7 times, 5 times, whatever you say, but what is important for them is what is their absolute risk of having a problem with the medication. So the risk in the general population is 1% of cardiovascular malformations. The risk with methylphenidate in these studies was 1.63%. And they didn't identify any risk of malformations with amphetamine salts. So this is very reassuring. Then what happens later on with pregnancy outcomes, So this big study where 0.2% were exposed to ADHD medication during pregnancy. So there were women that took the medication during pregnancy, and there were also women that took medication before pregnancy and after pregnancy. They saw an increased risk for NICU admissions in both cohorts, the one that took medication during pregnancy and the ones that took before and after. So they thought it doesn't seem it's related to the medication, the increased NICU admissions. But then they saw more risk of preterm birth and CNS disorders, and that seemed more related to the stimulant. And in this study, they didn't see risk for congenital malformations or perinatal death. In prior studies, they saw low birth weight, preterm birth, smaller head circumference, and feeding problems, breathing fast, lethargy. And as I said before, some of these studies were done in women abusing stimulants. So it's hard to say and extrapolate to women that use it at therapeutic doses. But it's important to know that there might be a risk of preterm birth in this population. During breastfeeding, and as I said before, it's a time very difficult for women because of the additional life pressures of having a baby. the information we have about breastfeeding with ADHD medications is really not there. I think there are like 5-6 studies about it, and they see a low level or undetectable levels of stimulants in breast milk, and they didn't see adverse events in these babies. These studies usually are case studies, like they tell you they had like 3 patients, and these 3 patients happened, you know? It's not like big population-based studies. So we have limited information about it. So when will you give a medication like a stimulant during pregnancy or during breastfeeding? You know, and it's a risk-benefit decision. And the important thing is to think how much the woman can't function without the medication. So a lot of women will be able to stop the medication during pregnancy and during breastfeeding. However, some women, and as I said before, like women that are having difficulty driving, or that they have to work to support their family and they are doing bad at work because they don't have their medication, or they can't really function without their medication, you might need to continue it. Also, during breastfeeding, when you want the woman to be able to function and take care of the baby. So those are times that you might need to put it in a balance and see what's more risky. And one thing that I mentioned here is that instant release versus sustained release formulations of the stimulants. And one thought is that if you are going to use these medications during breastfeeding, you might want to use the instant release because it peaks faster at 1 to 2 hours, different that the sustained release formulations might peak the medication in the bloodstream of the mother and then in the breast milk at 6 to 8 hours later. So also women that take instant release can manage it more as they want. So one day they might take it a little bit earlier, the other day they might take it a little bit later or not take it. So it might be a good idea to use instant release. So any question, anything I didn't mention?
Hi.
Yes.
How are you?
Good.
Good. See, I don't necessarily have a question, just a comment. I used to work on inpatient psych. I was one of the social worker case managers down on the adolescent unit. And our psychiatrist at the time down there, Dr. Blodgett, he's ADHD himself, like out the wazoo. So that was always kind of on his radar. But we were seeing this theme of adolescent girls coming in, and these girls were super anxious. They were super depressed. They were struggling in school. And so ADHD was always kind of on his mind. So we started kind of looking at that more closely. And kind of the theme we were seeing is that like all of these, like not all, but so many of these adolescents were undiagnosed ADHD, more primarily, inattentive type. But their symptoms were manifesting with, the anxiety, the depression. School was getting harder. And so they were having a more time focusing. So then their self-esteem dropped and confidence dropped, and then depression increased. And it was really, and kind of that I really kind of hadn't seen that connection like that, or wasn't aware of it, but it was just really interesting. And so he would start these girls on stimulants, and they were like, symptoms were drastically improved in like a really short period of time. So it was cool to see. Yeah,
I think I agree, like you can help them so much, because it's like their lives are falling apart, and suddenly you recognize the ADHD and you help them with that, and things turn around, and initially when I started, I wasn't so able to recognize it. So I had patients that, they had ADHD maybe, or I've diagnosed it, but I didn't realize that the mood symptoms were really related to the ADHD. So I might treat the mood symptoms and they weren't getting better, until I realized you have to treat the ADHD.
Well, that's what I like about ADHD meds. And that's what I would always tell parents is like, you're going to know right away. Like, this isn't an SSRI where it's going to take 4 to 6 weeks. Like, you are going to know if that medication is going to be effective like really, really quickly. And there seems to be, and I think parents liked that. They liked knowing that, like, okay, we're going to know right away, we're not going to keep our kid on this med forever if it's not going to work. And the results were a little bit more immediate.
Yeah.
And I think too,
Yeah.
it kind of, both the kid and the parent would be a little bit more bought into treatment, you know, and then like bought into continuing medications and then continuing some therapy and some psychoeducation, because they were like, oh, like, we understand this and we're seeing the benefit already.
Yeah, that's right. Yeah. Yeah, I don't know. I see a lot of women, you know, that are kind of falling apart because of this, you know, and not functioning and not underachieving really. You know, they can do so much better in life. And the thing that is like that it has such a genetic relationship, you know, and that it can run in families. So sometimes women, they have a child and then the child has ADHD and they have ADHD. So it's so difficult for them, and they don't know they have ADHD, you know, or they don't know the child has ADHD. It's so difficult for them to deal with all the situation. They just see their child maybe hyperactive or impulsive or not behaving or not doing well in school, and they don't know what's going on. But it's
Do you know
so
what the
important.
numbers are? Like what the rates of genetic
I think
pieces?
it's up. I want to say like almost 80%. I don't. Yeah, I think it's really high. Yeah.
Incredible.
Yeah.
But then what about on the flip side? Like on the flip side, ADHD is getting a lot of attention right now, and everyone thinks they're ADHD, and there's all these like pop-up clinics online that are diagnosing people with ADHD and sending them stimulants, and it might not be appropriate. So how are you navigating that? Because then I've had so many clients say like, oh, I think I have ADHD, and then they're really convinced they have ADHD, even if maybe the symptoms aren't there.
Yeah. Yeah. So that's always difficult when somebody comes very sure they have a diagnosis. You know, it's really hard to say no. You know, I think it's something totally different. You know, but you do it. Like what I do is usually I say, you know, I think what's going on is like you are bipolar, let's say, or you have depression. I don't know. And then I say, let's try the medication. I think will help you. Let's give it some time and then we'll reevaluate, you know, because sometimes we are right, you know, it's just that the comorbidities are so much that you might not see the ADHD as they see, you know, but sometimes it's not the case, you know, so.
But I think too, since it's gotten so much traction, people know what the symptoms are.
Yeah, that's very different.
They can very easily answer those questionnaires in a way that
Totally.
present in an ADHD diagnosis, or
but that's why it's important, the collateral.
Yeah.
Like say, who can I talk to? Or do you have any reports from childhood? You know, like had a patient, she had all her report cards from childhood. And there were notes from the teacher saying she is not paying attention, she's daydreaming, you know, but nobody.
And that poor girl who all those years she could have been treated. Yeah.
Yes. Yes. So I think getting collateral is very important. It's more difficult when you are dealing with an adult, because they might say, I can tell you everything. Why do you need to call someone? You know, like, but I tell them, you know, sometimes other people can notice it much more than you, what you're, you know, like how you behave and what you do and what are your difficulties. It's always good to talk to people that know you and are close to you. So,
Yeah.
I had a question.
Yes.
So is there any screeners? So, I mean, we screen for depression, we screen for anxiety and bipolar and all these things. Are there any ADHD screeners that can be used during pregnancy if they screen positive for depression or anxiety? Should we throw an ADHD screener on there if they're also discussing these other symptoms? Like, does that exist?
So I didn't see a scale done particularly for pregnancy. but you can use the ones that we have, I don't think none of them are really validated for pregnancy in particular. But and we don't know what happens with ADHD symptoms during pregnancy, so if it's real that they don't change so much, like you can use any scale, like that is available really. But really we don't know. I think there is so much to know about this. Like it's like a field that it's just becoming more recognized,
Yeah. Do you recommend any screeners?
So I use the adult self-report questionnaire, but I agree with what Megan says, like people can tell you, they can complete it as they want, like, and it can look very much like that's what happens to me. I base my diagnosis in my interview because when I always ask them to complete a screen just to kind of support my interview, but if they feel they have the ADHD, they will complete it in a way that looks they have ADHD,
Yeah, okay.
Kelly, we use the ASRS, the same one she's talking about here. But I mean, I think again, like you said, Dr. Frieder, like as support for documentation, but I've listened, I like could be a poster child family for ADHD and like undiagnosed in me and never came around to it until my children had it, and looking for the common thread, right? And anxiety subclinically treated, and like could just go on and on and on. So I've listened to a ton of information and podcasts and all these things. And what has helped me with screening people is having specific, like instead of I'm trying to open it, there's one that's like, do you finish projects or something? Like ask them what their nightly routine is. How hard is it for you to make dinner? What happens in that time? Like, because it's just a really hard subjective thing to say, oh, do I ever finish projects? Do I not? Like some of them know right away, but if you can come up with specific examples or tell me about what happens when you have to walk across the house to the pantry to get an item, like what happens in your mind?
Yeah. And what do you do? Because you might on the way get distracted and go someplace else, Yeah. I totally agree. And I think one thing I want to say is that when somebody sends me a patient for a consultation, and if like, let's say Leslie is sending me a patient and she tells me, this woman has a lot of symptoms of ADHD, like that for me is so important because she knows her already and she sees it, so that helps me a lot. So that's when I say that the collateral is so important. But on the other side, like, sometimes mood disorders and anxiety can manifest with symptoms of inattention, of forgetfulness, and sometimes it's hard to differentiate. So I guess the other symptoms that come around are helpful. So I guess, Kali, your question about like if you should do it for women that have depression, that's a great question. I would like to start doing something like that, like have a rating scale and give it to every woman that has depression or anxiety or not, like, like just anyone that comes. It will be so interesting to see what's the prevalence in these populations. More because some of these populations are at high risk, they are already using substances, they might have impulsive behaviors, and they might meet criteria at some point.
I've found a lot in moms, women, myself, but a lot of my patients, one of the biggest things that brings them anxiety or stress or a sense of not being adequate is overstimulation. They'll tell you like, I can't, the baby's crying and the toddler and the dinner and I like, can't everybody shut up? I need to just like run away. And that I've found to be a really consistent symptom. Not always, of course, it can go with other things, but that is one of them. Having alarms so you don't forget things like medication.
Yeah, I like that about overstimulation. I had also patients with rejection sensitivity, you know, and so I see that. Like I'm thinking about things that might not be written so much, you know, hyper focus.
Hyperfocus, perfectionism traits, and then how that starts to impact when they aren't able to meet that anymore because of a growing family or increasing.
Yeah, because one of the things that happen on any ADHD is like if you are very interested in something, you can do that. You know, the biggest problem is when you're not interested in things, you know, but if you are very interested, you will focus and you will be there forever, you know. So and people think, oh no, they don't have ADHD because look, they are concentrating, you know, they can focus. So
yeah. Or I remember telling people like forever and ever, if in college, if I had a paper to write, I had to have the time to start it and finish it in one session. Like it's very difficult for me to start something and leave it and come back to it. So being able to just hone in like the procrastination, I guess, until you absolutely have to do it. And then by having time to be able to finish it. There's something else in women that just went through my head that I see often. Gone. Do not remember.
yeah, but yeah. And I think we need more information about how to treat in pregnancy and postpartum, you know, so we are starting to treat them and we are more able to do it with the information we have so far. One medication that can be used for ADHD is bupropion. But the reality is that for somebody that has mild symptoms, it might work. But if you really have more intense symptoms, I don't see it working so much. But it has more information. It doesn't have risk of malformations. It's well tolerated in pregnancy. So that's a possibility.
Is that used for anxiety quite a bit too?
No, it's used more for depression and for sometimes when people want to stop smoking, they use also bupropion. Supposedly it can increase anxiety. My experience is that some people tell me it helps with their anxiety, but I wonder if it's because it helps, you know, the depression and maybe the inattention symptoms, and that makes it to help with anxiety. And then I was looking about data about atomoxetine and other things, and there's no data in pregnancy, you know, so I try not to go there in pregnancy. The other one that I try not to use so much because there is less information is Vyvanse, but if you need to, you know, it's a risk-benefit decision, really. But I try to go with the ones that we have more information.
Oh, I know what the other thing I was going to say was. Hobbies, switching, if you ask these people like what they want or what they're interested in, or have you ever bought all the things for, like, you're gonna be a knitter and you buy books and all the materials and supplies and whatever and be interested a few weeks and then never touch it again, and they'll kind of bounce around from interests and hobbies.
Yeah. And somebody can see it very much as like if they start buying a lot of things and spending a lot of money on it, they can see, oh, maybe she's bipolar, you know, like,
Mhm. Mhm.
but there is that impulsivity and in ADHD. So
Mhm.
any other thoughts?
One other question I had, I've reached out to some therapists that I found on Psychology Today that say they specialize in ADHD, and I'm not getting any phone calls back. Does anyone have any ideas of any therapists across the state that offer telehealth? I'm up here in Kalispell, that specialize in ADHD therapy for, I mean, we've had a huge influx of patients recently with either diagnosed or in the process of diagnosis for ADHD in pregnancy.
I'm not sure. Really.
I'm not
You
sure of
know,
any,
Megan?
well, I'm just trying to think. I'm not sure of any specific for ADHD. It's interesting about the Psychology Today, because I had put out a bunch of emails to different people on Psychology Today recently too, and I didn't hear back from anyone. So part of me wonders if there's some kind of glitch happening.
You know, I think it needs to be somebody that knows how to do CBT, you know, because then
Yeah.
you can do it for ADHD, you know?
I think Christine Reed Tobin, she's here in Billings. She's trained out at the Beck Institute for CBT, and she's got quite a bit of personal experience with ADHD herself. So I know she's quite knowledgeable in the area.
Okay.
Susan Frew has also trained out at Beck Institute. She's a fantastic CBT therapist. They're both here in Billings.
Okay. Okay, thank you.
Yeah, you're welcome. I'll try to
I think
recommend
that's so important, you know, like paying attention to the psychotherapy part, because that will help them to learn skills and how to deal also with their symptoms. So it kind of goes together, you know?
There's also, I really like to recommend the book Smart But Scattered to families or individuals. I think that book does a really great job of kind of breaking it down, explaining it, giving tools, resources.
What's the name of the book?
It's called Smart But Scattered. Yeah, it's a good one.
But I think it's important what we are saying and how to have more information about females and how it manifests in females, you know, because like it's not just being inattentive, it's not just maybe being a little impulsive, you know, like what's going on with the whole person, you know, how it affects your whole life, you know. So the other thing I wanted to say is that some people might have ADHD symptoms, but they might not meet criteria for ADHD, you know, but they might had it when they were children, and now, you know, this is what it's left, you know, and they still might need treatment, but they might not have all the, you know, the features of ADHD as an adult, but they still might not be functioning well. So it's important to recognize them, still recognize them, you know, and help them.
Would you treat those people with medication still?
Yes, yes. It's a little bit more difficult when you need to get approval from the insurance, you know, like
Sure.
sometimes if you don't have a complete diagnosis. But
Dr. Frieder, do you, and maybe this isn't like during pregnancy, but in women in general, how do you differentiate or decide stimulant versus non-stimulant versus combination? What drives that decision for you?
so first of all, if if they have a history of substance abuse.
Then
So
non,
if they have a history, I go with non-stimulant. If they have any cardiovascular risks, you know, or anything that can put them at risk with a stimulant, I try to go with a non-stimulant. Then really depending on the severity for me, because like if somebody comes to me first time they are diagnosed, but they are really falling apart, I don't know if I want to start them on Wellbutrin and see if it helps, you know, because it might, most likely it will not help. That's my experience, you know? So I might start them directly on stimulant. And what I do, I start on stimulant and see how they do.
right.
And then you see, what do you need to do? Do you need to add something? Do you need to keep it this one or change to a different one, depending on the response?
Okay. That was my thought process. I just wondered if you had a method for that.
Yeah, basically it's that. I'm trying to think what other people I will use. So if somebody wants to stop smoking, I might say, let's try the bupropion first, you know? But basically, I really want to rule out any substance abuse. And when I start a stimulant, I always start sustained formulations, sustained release formulations. Like I don't like to give the instant release because it has a higher abuse potential. So if needed, I give it, you know, but I try to start with the extended release formulation.
Then I also have found that sometimes people with abuse history, stimulant is like exactly what they need to remain sober, or, you know, like they need that intensity of a medication. When would you consider this person to be stable for that?
That's a great point, because we know that some people use the substance to cope with their ADHD,
Right.
you know, so I will want the person not to be abusing substances at the moment, you know, like if somebody is on cocaine, I'm not going to give them a stimulant also, you know, so how long of sober? I'm not sure, you know, like,
I know there's not hard and fast rules, but
yeah.
okay.
Any other questions? Good. So I'm glad we spoke about this subject. It's so important.
Yes, thank you so much.
So I think next month we'll talk about eating disorders.
The date next month, we know.
I think it's let me see, I'll tell you, either the 10 or what is it? The 10.
On the 10th, so in 2 weeks?
May 10th. May 10th.
May 10th.
In a month. Yeah.
Perfect.
Okay. Thank you so much.
Yeah, thanks, Dr. Frieder.
Thank you.
Take care.
Bye.
Sure. Bye. Bye.